Welcome to the Code AAA Policy and Procedural Review module. In this course, we will highlight the updates and changes that we've made to our Code AAA policy. Be sure to look for the change icons that denote the key changes to our current policy. Our goal is to remind staff of key goals to be achieved when a Code AAA is called in the hospital. We want to increase awareness of the critical steps that should be taken when a Code AAA is called based on current evidence-based practice. Processes for policy and protocol development and revision are now based on the inclusion of best evidence, clinician expertise, and patient values or preference. We want to improve communication amongst nurses, physicians and surgeons, and department directors during this type of code, as interdisciplinary communication decreases fragmentation of care and improves quality of care. The ultimate goal here is to improve our processes in place for treating patients who present to the emergency room with a AAA in order to optimize patient outcomes, reduce errors and wasting of time, and to optimize resource utilization. What is a AAA? A AAA is an abdominal aortic aneurysm that occurs when an area of the aorta becomes very large or balloons out. Rupture of this aneurysm is considered a true emergency. The incidence of an aortic dissection is about 3 in 100,000 cases per year, which is half the incidence of symptomatic aortic aneurysms. The mean age at presentation is 63 years of age. Male predominance is 65%, which is 16 in 100,000 men. Despite women being less affected, outcomes are much worse due to delayed diagnosis and presentation with atypical symptoms. AAAs occur mostly in the infrarenal aorta as a result of loss of collagen and elastin with the media and adventitia. Scientific types include congenital, infectious, and inflammatory. Risk factors for this condition include smoking, age and sex, family history, and other associations of disorders to include Marfan syndrome, hypertension, coronary and peripheral vascular disease, central obesity, and hyperlipidemia. We need to be able to promptly recognize the symptoms of a AAA when a patient presents to the emergency room. Most AAAs do not have symptoms. Medical exams sometimes uncover a pulsating mass in the abdomen, and often the aneurysms are discovered by accident when a patient has an imaging exam such as a CT, MRI, ultrasound, or another condition. Emergent symptoms include severe sudden pain in the abdomen or bag, which is a sign of a bursting AAA. Pain may spread to the groin, legs, or buttocks. Clammy skin, dizziness, rapid heart rate, passing out, and shock are also emergent signs. According to the American Nurses Association scope and standards of practice, we must assess our processes in light of current evidence-based practices to identify our potential issues or problems and institute improvements by way of coordination, collaboration, and education to improve our quality of practice. Our policies have a huge impact on the healthcare we deliver as they ensure our care is safe, of high quality, accessible, and affordable. Therefore, it is important to continually assess our policies in place to ensure that our processes are optimizing outcomes for the sake of patients, all care providers, and key stakeholders. So what are our issues here? We have gaps or shortcomings in the currently established policies and procedures associated with our Code AAA policy. A Code AAA has been called on patients with thoracic aortic aneurysms in addition to the patients with abdominal aortic aneurysms, which is not an appropriate course of action. While some studies conducted can offer justification of evaluation for abdominal aortic aneurysms in patients presenting with thoracic aortic aneurysm symptoms, this justification does not translate to the utilization of a Code AAA on this patient population. This results in miscommunications and lack of appropriate information being conveyed with when these patients present to the emergency department. There is a lack of physician discernment to determine the course of appropriate actions, and consequently, processes are being employed that are irrelevant and not useful for the presenting circumstances, which imposes wasting of valuable staff and supply resources. By having a code AAA in place, we hope to expedite surgical care, improve patient outcomes, and optimize the mobilization of resources such as the OR and radiology personnel, as the endovascular era is resource intensive. So, why do we want to implement a code to address our AAA patients when they present to our emergency department? Remember that rupturing of an aortic aneurysm is a true emergency. Mortality is very high at 14% in patients with ruptured aortic aneurysms. This is slightly higher than the 11% for trauma patients. When comparing trauma code patients to those with ruptured aortic aneurysm patients are deemed equally unstable, with similar mortality rates and more likely to receive surgical interventions. Yet the response time to physician assessment was significantly less for trauma patients, which is likely due to having a code process in place. Therefore, we want to address the needs of our AAA patients as promptly, effectively, and efficiently as we do our trauma patients. Let's take a closer look at the policy and the changes we have made. We have expanded our definition to include a more detailed classification system to help determine the most appropriate course of action. A code AAA will be called for acute ruptured infrarenal abdominal aortic aneurysms and by a vascular surgeon or interventional radiologist after review of images and/or discussion with the referring physician. Here is a new addition to our policy, the classifications for varying types of aortic dissections. This is important as it can help determine the course of action for treatment. The Stanford classification is more commonly used and is based on the involvement of the ascending aorta, and it is a more simplified version of the DeBakey classification system. It divides dissections into two types, type A and type B. Type A involves the ascending aorta, type B does not. This system helps delineate treatment. Type A dissections typically require surgery, whereas type B dissections may be managed medically under most conditions. The DeBakey classification system divides dissections into three more detailed types. Type 1 involves the ascending aorta, aortic arch, and descending aorta. Type 2 is confined to the ascending aorta only. Type 3 is confined to the descending aorta distal to the left subclavian artery. We have certain time goals we need to meet when patients present with a ruptured aortic aneurysm. The time from triage to diagnosis should be 45 minutes or less. Then, once diagnosed, we must get the patient to the OR within 30 minutes, with the total procedural time taking no more than 60 minutes. This code will only take place at our Chippenham campus. A new addition to this policy is the note that a code AAA will not be called on patients presenting with thoracic aortic pathology. If a patient has a confirmed positive thoracic aortic dissection, the patient will fall into one of the two pathways, type A, 1, 2, or type B, 3. Upon confirmation of a type A or type 1, 2 dissection, the attending or emergency department physician will place a stat cardiac surgery consult. From there, the cardiac surgeon will determine if the patient is an appropriate candidate for surgery, and if so, he or she will notify the nursing supervisor to call in the cardiac OR team. If the patient presents as a type B or type 3 dissection, the attending or ED physician will place a stat consult for both the cardiac and vascular surgeons on call. From there, the vascular surgeon will notify the appropriate endograft vendor or representative about the case for review of the images. Both the vascular and cardiac surgeons will review the images and determine further appropriate course of actions and interventions. This can be either a thoracic endovascular aortic repair, also known as a TEVAR procedure, an open surgical repair, or simply medical management where the patient is admitted to the cardiovascular intensive care unit and where type B dissection order set will be instituted and carried out.